Righty. Hello and welcome from wherever you are tuning in today. Thank you so much for joining us at the Center for American Progress for what we hope to be and expect to be a fantastic conversation. My name is Haley Gibbs, and I'm a senior policy analyst with the Early Childhood Policy team. I'm also delighted to be joined by my friend and colleague, Ali Schneider, in hosting this event. Ali is also a co-author on our recently published report series on the social determinants of health across early childhood development. I would like to start off with just a little bit of housekeeping. Today's session will be recorded, and that recording will be posted to CAP's website. We have closed captions available using the tab at the bottom of your screen. And for accessibility purposes, I'd also like to note that my pronouns are she, her. I am a white woman with reddish blonde hair and brown eyes. My background is a blue CAP branded screen, and I'm wearing a black top with a greenish blazer. We will also be taking your questions at the end of our session today, so please feel free to submit them using the questions tab at the bottom of your screen. And with that, let's dig in. The earliest years of a child's life are a critical time for development, during which children are particularly sensitive to their social and environmental contexts. A range of both clinical and non-clinical factors, including healthcare access, housing and food security, neighborhood and environmental safety, and educational access, shape the conditions into which children are born and raised, setting the stage for all subsequent health and development. Moreover, historically and today, systemic racism has been a driving force in creating and perpetuating many of the disparities that children face from and even before birth. In a broader social and political landscape that often doesn't consider how quote unquote adult or community level policies and programs have meaningful impacts on children, it's critical that we advocate for policymaking that reflects an understanding of those impacts. In particular, we must work to foster an understanding of development as a continuous process that absorbs the impact of broader policy decisions and social, environmental, and economic conditions in order to craft holistic policies and interventions that ensure every child has a chance to thrive. We're joined today by a panel of 3 outstanding experts, and we'll share out a resource in our chat with additional details so you can get to know our panelists a bit more. But for the purposes of our session, I'm very happy to introduce Alicia Hardy, who joins us from the Center for Law and Social Policy, where her work highlights the importance of equitable data collection and analysis, as well as understanding the roles of racial equity and intersectionality in improving state and federal policies to support children, families, and the childcare workforce. We are also joined by Patty Cole from 0 to 3, who brings extensive expertise on infant and toddler health and development. She's also contributed to the publication of 0 to 3's annual State of Babies Yearbook and comes with a breadth of Hill experience. And last but not least, we are welcoming Alex Briscoe, who joins us from the California Children's Trust, where his work as a trusted expert on mental health reform focuses on designing and administering mental and physical health programs and services to improve the well-being of California's youth. Thank you all so much for taking time out of your very busy schedules to be here with us today. I am now happy to pass the mic to Ali to lead us through our discussion.
Thank you so much, Haley, for that introduction, and welcome everyone. My name is Ali Schneider, and I'm a research associate on the Early Childhood Policy team here at CAP. And for accessibility purposes, I'd also like to note that my pronouns are she, her. I'm a white woman with short brown hair and blue eyes. And I have a blue CAP background, and I'm wearing a dark green button-down sweater. I'm very excited to guide our discussion today about the role of holistic public policymaking, equitable data and research practices, and community-based services in addressing the unique needs of young children and their families in advancing long-term health and educational equity. Just a quick reminder for each of our panelists to give a brief visual description of themselves when you speak for the first time. And with that being said, Patty, I'm going to turn over to you first to get us started and lay a little bit of the groundwork here. So Haley touched on this a little bit in the intro to our conversation today, but I wondered if you could bring some of your experiences working on 0 to 3's annual State of Babies Yearbook to level set. What are the social determinants and why are they so important to consider in relation to the well-being of young children? And as I'm sure you can bring in from 0 to 3, why infants and toddlers in particular?
Great, thanks, Ali, and thanks so much for having me. So I'm Patty Cole. I'm the Senior Director of Federal Policy at 0 to 3. My pronouns are she, her. For accessibility purposes, I am a white woman with brown hair, brown eyes. I'm wearing a tan sweater, and my background is 0 to 3 branded dark blue background. So the social determinants of health are particularly important for babies because they're not simply shaping health outcomes in the way we might think about for adults. They're shaping the development that is the foundation for all later learning, as well as their health. So high levels of poverty, lack of quality childcare and other early learning programs, the environment in which babies live, not to mention the quality of the healthcare for them and their parents and caregivers, all have an impact on whether early development is strong or fragile. So the 5 areas of the classic social determinants of health model that apply to babies are healthcare access and quality. And health is a foundation for all aspects of babies' development. Access to quality healthcare is also a 2-generation concern for babies, as their health and emotional well-being is intertwined with that of their parents. And it's particularly brought home right now when we are really in the midst of a growing maternal mortality crisis and maternal health crisis. Economic stability, material hardships due to poverty and low income can really undermine babies' development and long-term health, weakening the foundations for later learning and achievement. Babies have a high rate of living in low income, and this is particularly true for Black and Latina babies, as well as Native American babies. So I'll talk in a minute about equity considerations. The social and community context is really the positive relationships and interactions with parents and caregivers that are really the bedrock for babies' development, especially their social emotional development and their cognitive development. Education access and quality, talked about childcare, both the formal and informal opportunities to support that early development and learning that occurred within home and in education settings. So that sets them up for lifelong learning. And finally, neighborhood and built environment. And I think this is really important for babies because we may not always think about it. Housing and neighborhoods play critical roles in creating a healthy living environment for babies and pregnant people. And so environmental problems can start even before birth in the prenatal period, but also housing particularly is just a critical part of the sort of social and emotional heart of a family. So when we started our study of social determinants of health at 0 to 3, we were trying to use our State of Babies data to illuminate how babies are faring in these areas, to really give policymakers actual data they could use to kind of measure how babies were doing. The benefit, I think, of using this framework that we found is that it can help policymakers better understand the breadth of factors that affect early development and therefore policy, and see how they're interconnected. And then by using the data, show something of the magnitude. For state policymakers, we're trying to give them a roadmap. Take your data, do the same assessment. But the last point I want to make is that equity is a major focus. And I think that's what we got from using our data within this framework. And it underscores the disparities and how infants and toddlers of different races and ethnicities, as well as income levels, experience all these factors that shape their future. And you really, in turn, illuminate the pernicious role of racism in setting up these determinants for many babies. So we hope that it's a really strong policy starting place.
Great, thank you so much, Patty. And yeah, that's definitely true. The social determinants, it's not a new framework, but really grounding those in those earliest years of life is just so important. Alex, I wanted to turn over to you next. And I know a lot of your work is focused on the administration of state and local programs as a way to reorient child serving systems towards achieving social justice and reducing disparities. I was wondering if you could bring up some of that experience into talking about just the role that state and local officials play in supporting whole child and whole family policymaking.
Yeah, thanks. Well, I feel like the Medicaid geek in this conversation. So for everybody listening, if Medicaid makes you throw up in your mouth a little bit, I totally get it. But we can't get to where we want to go unless we reimagine Medicaid as a strategy for healing and justice and equity. So I think that begins first and foremost in reimagining this term we call medical necessity, which means how do you qualify for care? And historically in Medicaid systems, across America, you had to meet specific diagnostic criteria. And our work in California now being adopted nationally is like, that's not actually consistent with the amendment to the Social Security Act of 1967, meaning that children in Medicaid do not have to meet a specific diagnostic criteria to qualify. And this is really important for children 0 to 3, 0 to 5. And I want to acknowledge Patty and 0 to 3, Raheel Briggs and Jen Tracy and many other spirit guides we've had in this work. But basically, one of the most important things health systems can do is take a look at that definition of medical necessity in benefit design and waiver construction. And instead of meeting diagnostic criteria, things like an experience of discrimination or housing insecurity or food instability should qualify you for care. And I can say, as a defunct therapist who's literally billed hundreds of millions of dollars of mental health services to Medicaid, that very few of the families I served were actually mentally ill. Almost all were dealing with really bad stuff in their lives and living in a culture that equates fame with merit and wealth with value and is built on 400 years of structural inequality. So we have to reorder the front end of our system so it actually reflects what is driving the challenges. And this is super important for kids 0 to 5, because when you look at any Medicaid system, that population has the lowest access to mental health services of any demographic in Medicaid, because what pediatrician is going to diagnose a kid who can't walk or talk? Like, it just doesn't work. So redefining medical necessity and then reorganizing your benefit construction to reflect the type of care that everybody wants to practice, which is what we call dyadic, what 0 to 3 calls healthy steps. There are a number of evidence-based practices that meet this criteria: child-parent psychotherapy, trauma-informed cognitive behavioral therapy, parent-child interaction therapy, and healthy steps are the 4 that I would call evidence-based. All are viable. Very few exist in Medicaid reimbursement practice and policy. California just adopted the dyadic benefit January 1st of this year, making healthy steps a reimbursable service. And I'll close with this comment. The advocacy we did to create that benefit began with a paper called "Babies Don't Go to the Doctors by Themselves." You don't even need to read the paper, okay? You kind of got it, right? Like, low-income people interact with the healthcare system the most frequently when they take their babies to the doctor. 10 to 15 times in the first 3 years of their child's life. And FYI, don't believe the hype. Poor people show up better for their kids than privileged people do. They have a lower no-show rate for well child visits than the commercial population, despite all the barriers. So it's an extraordinary time to do this kind of work. So my invitation to all the panel, to everyone listening today is, don't throw up in your mouth when you think about Medicaid. It's really important. It covers half of all kids in California. Get at that eligibility criteria, what we call medical necessity, change it to reflect what's truly driving challenges in low-income families, and go at pediatric primary care really hard with new benefit design and managed care.
Thanks, Alex. And I love that title, "Babies Don't Go to the Doctor by Themselves." It's definitely very catchy, and yeah. And I also appreciate you bringing in that connection with healthy steps in 0 to 3. That's super important as well. Alicia, I wanted to turn over to you next to talk about some of your work and kind of how the social determinants fit into that as well. I know your work encompasses a number of critical issues around data collection, racial equity, childcare access, and wraparound services for families. And I was wondering if you could just talk us through, in your perspective, how those issues are connected, and a little bit about maybe how you view the social determinants in your work.
Absolutely. So I would say that in my perspective, the way these issues are connected are through the experiences, needs, preferences or norms of children and families. Even from early in life, none of us have the exact same experiences, needs, or norms. Even when we are too young to really express this or recognize this, our families and communities do. As Alex was talking, babies don't go to the doctors by themselves. So our families are there, and they are aware of these differences. So even when we talk about data, those experiences, needs, and norms that are attached to people are always present. And so when there aren't considerations or ways to incorporate that variation into how data are collected and used, this can lead to unintended harms, especially for those who are marginalized. So as an example, increasing investments to expand the supply of childcare without creating pathways for providers serving families working non-traditional hours, making sure that those who speak a variety of languages can access information and technical assistance, or making sure that policies account for intersecting systemic economic inequities in Black, Hispanic, and communities of color as it relates to startup costs for opening a childcare business. Without these considerations, it would lead to unintended harms of further exacerbating inequitable access to care. So connecting all of this together, we can really start to see how access to childcare and wraparound services, both of which are well-intended and to support and improve well-being from early in life, we can see how they can inflict harm. Because when policies guiding these resources marginalize the experiences, needs, and norms or preferences of communities, it centers on race, and it can often intersect with ethnicity and language, and disability status, familiar structure, geography, income, and a variety of other characteristics. And so essentially, this marginalization creates a cycle of elevating a standard that's devoid of any critical context in favor of a narrow definition of well-being and what is needed to achieve it. A definition that ultimately shapes policies that dictate how funds are allocated, what programs are created, services offered, and how to access them, and so much more. So all of this is truly connected through people, who they are and what they need.
Thanks, Alicia. And we're going to dig into that a little bit more. And I see, Alex, you just unmuted yourself if you wanted to go ahead and, yeah.
Well, first of all, Alicia, you're awesome. Thank you for saying it that way. Like, we have to remember that these systems are not run or privileged the people who need access to care in them. So shifting agency, meaning who does the work, and power, who gets paid to do it, is really important for any kind of just and equitable outcome for little kids and their families. And so you're seeing this in the Medicaid space through the expansion of the eligible provider classes. And I think this is some of the most exciting work that's happening in early childhood, is states creating doula benefits, community health worker benefits, peer counselor benefits, and wellness coaches benefits. Those are the 4 we created in California in the last year and a half. And I think this idea that there is a wisdom and intelligence in communities that can be reimbursed is a very, very powerful way to address some of the unintended harms. People aren't trying to do wrong. I'm with Alicia, but some of this understanding of wellness is a white frame. And in California, at least 80% of young people on Medicaid are children of color. 80% of the professional class that serves them are white. And white people are cool. I ain't got no problem. That's not the whole point. But there is a disconnect there that must be addressed. And the new provider classes are a super interesting way to get at some of the issues that Alicia just raised.
Definitely. And Alex, kind of coming back to you, you've already mentioned this in what you've talked about so far, but we know that children's health is so intricately connected to their caregivers. And I was wondering if you could talk just about more about that dyadic healthcare model and the way that pediatric providers can treat children within the context of their families, and just give us some more details on that.
Well, I'm sure Patty has probably been working on this issue for 30 years. I mean, go back to Brazelton's touch points, to best baby zones. I mean, we've known that children grow in the context of their caregivers from attachment theory on out. So, but what we haven't done is crosswalk the critique to the reimbursement practice. Okay, so to get unsexy for a second here, the dyadic benefit in California, which is now being adopted in New York and Massachusetts and other states, is basically just a CPT code strategy for healthy steps. Patty, that's literally what happened. Like, Jen Tracy and Raheel Briggs at National 0 to 3 connected me to this amazing psychologist at the highest volume pediatric primary care site in San Francisco County, 14,000 unduplicated kids. And literally me and my team followed Dr. Kate Margolis around her clinic for 6 months. And when she did something, we tried to code it. Like, it sounds maybe like it's a big innovation. It was an innovation. We literally just CPT coded healthy steps and then spent 2 years negotiating with the state, because California looks good on paper, but in practice, little kids get very, very poor care in California. 44th in the nation, 48th in screening, like really tough stuff. Don't believe the hype. We look good on paper, not so good in practice. And so that's what that benefit design, which I know is, and I'm very proud of that work with many other people participated in it, but it really distills to crosswalking healthy steps to a set of CPT codes and then negotiating with our state benefits division. One of the learnings of that process was you don't need a waiver or any other federal approval because of EPSDT. So for those of you who know what that is, that's this unique status that children enjoy in Medicaid, tied to some changes that happened in the 60s to the Social Security Act. And it basically says kids get everything they need to grow up and thrive, like well child visits and immunizations. Like you don't have to have measles to get an immunization, right? So we basically leveraged that infrastructure to redesign the benefit and coded it following the Healthy Steps model. So I just want to say, get real practical for anyone listening here who's working in a state. Like, you know, the critique is not the strategy. We've had the critique. The strategy is very hard and true and specific and detailed reimbursement practice. If you want to change how things work, change how the money flows.
Definitely. And Patty, I know Alex referenced your work on this for 30 years. Did you have anything more to add on that?
Oh my gosh. So I can't personally say that I worked on Healthy Steps for 30 years, but I've certainly worked on that whole concept. And I think Healthy Steps and other similar models are really powerful in how they really reach both parents and then help parents support their children. But what I'm really in awe of is Alex. So at a federal level, we'll put that in one line if you should do this, but I'm really in awe of Alex and his colleagues actually figuring out how you take this opportunity at hand with Medicaid and its funding stream and figuring out how you get from what we want to have happen to the reimbursement that can really make it more widespread to more children. So I am in awe of that, as well as my colleagues here at 0 to 3. And I hope that we can then take that and really figure out how to elevate it so that it's, as you say, it doesn't require, maybe it's really focusing on how you try to realize the promise of EPSDT and really figure out how to push states to do that in ways that are really in that preventive and supportive and promotion area, rather than waiting until they have an illness to code.
And I just quickly like to note to our audience, we're getting some great questions, but feel free to drop those into that Q&A box, and we'll try to get to as many of those as we can at the end of our session. Alicia, I wanted to turn back to you, and I know you already referenced some of this in some of what you've already talked about, but I wondered if you could just, if we could talk a little bit more about your work around equitable data collection and analysis. And I know we know that data often drives and informs policy decisions. This is something that you said, but good data can be hard to come by, and especially in the early childhood space. And as you've spoken about in your work, it's not just about collecting more data. What are some of the dangers of inequitable data collection and interpretation in this work, and how are some of the ways that we go about approaching that?
Thank you for that, Ali. I do want to go back a second. I did not do my description. My name is Alicia Hardy. I'm a Black woman with coral colored glasses. I have a blurred black and white Soji screen behind me and a brown and white polka dot dress. So just wanted to do that really quickly. So yeah, that was a great question. So the dangers of inequitable data processes, because I think it's important to emphasize the entire data process, is exacting further harm on Black, Indigenous American, and other communities of color, and particularly those who have low incomes. But before going into those harms, I want to build on that data processes piece and connect it to how we get good data. And the way that we get good data, and Alex, you kind of alluded to this in one of your answers as well, is by examining and deconstructing the current process and how data processes center inequitable power structures. It's important to really understand that the standards and processes that dictate how we use data were created within the same institutions, systems, and structures that have been shaped by historic and present impacts of white supremacy culture and systemic racism, which also drive inequities in health, education, housing, and elsewhere. So I want to just unpack this a bit more in terms of this process. And so we often talk about data. When we do talk about data, we skip kind of to this collection and interpretation, these collection interpretation stages. But those are really only two components of the entire data process. And while the process will definitely look different based on a variety of factors, it will always begin with a question. And based on that research question, we then figure out what data are needed to answer it and how to get that data. And so there's so many decision points when we look at this data process. So it's thinking about one of the decision points. Some of these decision points include from whom those data are collected, who collects the data, and what types of data are used. If there are surveys or focus groups, who decides the questions, how they're worded, or what languages are used, and who manages the outreach for these participants, who interprets and synthesizes this information, or who determines what information is relevant and what's excluded. And finally, one of the more of the end parts of this process, who decides if the information is made public and how it can be accessed. And so you can kind of start to see the many decision points along the data process that really deeply impact whether data are good. And so the danger of inequitable data is that these processes often exclude, again, people with the direct lived experiences needed to reduce harm, while also creating policies that disproportionately harm those same communities. And what is instead centered is often associated with white, English-speaking, middle or upper middle class nuclear families with traditional work schedules. And so from these data, resources, policies, programs, and outreach strategies are determined, often without this important historical and social context from those with direct lived experiences that could be incorporated throughout this process. So when this critical context is missing, it creates space to place the burden of misaligned data and resources on communities, mislabeling them as hard to reach or uninterested or difficult. And this is dangerous because it ultimately validates and reinforces those inequitable power structures. And this happens when the desired improvements based on additional investments are not seen based on those programs and resources. It creates this space to weaponize that data. And data are weaponized when the resulting information is poorly contextualized and is used to critique individual level outcomes instead of systemic barriers to resources and services for those communities. And so ultimately, inequitable power structures are reinforced as this information is used to support why certain communities can't be trusted with the power to develop and implement their own policy solutions.
Alex, I saw you nodding along. Was there anything that you wanted to add there?
I want to make sure I don't say anything and let that rest with the, I mean, I can say I led one of the California's largest health systems for a decade, and everything Alicia just said, yes, that thing. Like, the systems do not privilege the needs and wishes and beauty and wisdom of the people they intend to serve. And that is, data is often weaponized to blame people in these systems for what I think the best example I'm seeing right now is the social determinants of health referral platforms. At least I don't know if you're tracking this stuff, but like Unite Us or Find Help or One Degree. This is a huge movement in the healthcare system where you basically create a digital closed loop referral system to help people access social determinants of health supports. And it's a good thing, right? If you've ever worked in a low-income community, you've like said, hey, where's the soup kitchen? Who's giving away free books or that kind of stuff, right? So it's good. But these systems are referring poor people out into community-based organizations with no resources attached. And so not only is that bad for those organizations, it creates a narrative that if poor people just knew where to go, they could get their needs served. And that's exactly the point that Alicia was just making, is like, we are not addressing the fundamental question, which is, like I can say as a defunct therapist, most of the people I served needed a good job more than they needed a good therapist. And so, like, we are not talking about, a healthcare system is not doing what it needs to do around economic justice and power to create opportunities for low-income communities to meet their own needs. What I sometimes say in the mental health space is the future of mental health looks a lot more like mutual aid, affinity groups, 12-step meetings, doula services than it does a 50-minute psychotherapy session. Like, we are facing a fundamental and acute workforce crisis in mental health. And in some ways, I think that's a good thing, because it will stop us from driving mental health utilization into traditional medical model programs, which have limited impact on health outcomes for low-income communities of color. So I think there's opportunity in some of the critique that we're talking about here, but yeah, I very much agree with how Alicia's framing it.
Definitely, and CLASP has some excellent resources on exclusionary discipline in preschool and early childhood settings. And this is an issue that disproportionately impacts Black children, Black boys, and students with disabilities as well. And I was wondering if you wanted to dig into that topic at all anymore, and any opportunities that we might have to like leverage existing systems to, it's an issue that of course we don't have. There's not a lot of clarity around. I'm not sure if that was a particularly eloquent question, but
yeah, I'm happy to touch on that a bit more. Thank you for uplifting that report. And when we wrote the report, myself and my two colleagues, Tiffany Ferret and Alyssa Fortner, when we wrote that report, we were very specific about centering Black families, the historical context of disproportionate discipline and violence dating back to times of enslavement for Black communities and what that looks like, and understanding how that historical context is now translated into the ways in which Black children are viewed as unruly when they are exhibiting the same behaviors as their white counterparts. When we look at the lens through which their behavior is viewed and subjectively critiqued based on environmental factors that are taken into the spaces that they're in with care, this is not necessarily something that's squarely on the providers, because I think that oftentimes when people hear this report or they think about this, they think we are in a position where we are saying, providers are doing this. I think there's definitely training and things that can be supportive, but it is a systemic issue. This is a systemic issue that's not being addressed. Even when we're going back to the piece around data, there aren't data, particularly for children who are 0 to 3, in terms of what discipline looks like. We don't connect discipline to young children, but there are exclusionary practices that can be happening. There's not ways for providers to even have the resources and supports to understand how they could be shifting practices, because these practices that they're instituting are systemically supported. They are encouraged in terms of disconnecting what's happening within families and communities, communication strategies that are all being, again, narrowly viewed through a lens of what centers whiteness and what it looks like to communicate in particular ways, what it looks like to have specific interactions, how children may behave, and it looks very different. So I appreciate you uplifting that. And it does connect the data to the policy, to understanding how both impact overall practices.
thank you so much. And also highlighting that, yeah, providers are not the only part of this picture there. Yeah. Hattie, I wanted to turn back to you. I know your work explicitly has a very Hill-facing audience, and I was wondering if you could talk a little bit about how we advance these issues to gain more traction around policymakers, and especially around the social determinants. And
Right. I mean, I have to say, I have so many thoughts running around my head after listening to Alicia and Alex. One is that this does relate to messaging about how you talk about is the contextualization of data. And I think that's so important. I've actually, if you just lead with data that to you is so self-evident of some problem, I've actually had a reporter just pick up a piece of data I gave around prenatal care and who has late prenatal care because they don't have access to early prenatal care, and totally misinterpreting it, and really brought home the need to give some context before you throw out data. And the other thing is that, and I think this is helpful in messaging, is really to think about the needs of the communities and empowering communities to shape the solution that fit their needs. And I think that is something that can sell to policymakers who are, especially those who are not in favor of solutions that come from Washington, is that how do you empower the communities? I will say that one thing about data is that the more you get, the more frustrating it is that you can't get behind it. And so there is, I saw a question in the chat about, how to get to different needs.
It looks like, Patty, you may be frozen for a second here.
It can be a struggle and frustrating, but it's so necessary. And in terms of talking about these issues and trying to advance,
Yeah, wait for 1 second, maybe the Wi-Fi is. Patty was having a few tech issues before he joined, so that might be the case here.
of having
Oh, all right, it's coming in and out here. Oh, Patty, I think you're back now.
I'm back. I hope I wasn't on mute for that whole time.
No.
No, I'm sorry. As you know, I'm having computer gremlins today, and fortunately, this only lasted a second. The last time it lasted 15 minutes.
Oh, no.
Anyway, but just using this frame, I think is really helpful of the things like the child tax credit that policymakers probably haven't even thought about being an important child development policy and helping them to see things in a different light. Our research has really found that the factors around shaping brain development and how that development is a foundation for all future learning still do resonate. The fact that these first years are critical for brain development, and that all of these different factors that you see in social determinants of health do play into that. Using both data and stories together is often more effective than just throwing out the data itself. And we collect stories and really have conferred a lot with our Family Advocate Network, which is made up of our Sterling Thunder families. And that's been just a phenomenal resource to really shape how we think and talk about some of our work. And I think two other things that I think people should keep in mind is sometimes we use messages so much that people immediately discount it. We've had anecdotally people tell us that return on investment just immediately makes them think that I don't want to listen to you anymore. And so you have to be careful about who your audience is. And I also think that sometimes there's trial and error. I think Alex's insights to what happened would help with that dyadic benefit, that babies don't go to the doctor by themselves. Sometimes you just really have to find that sort of fact, or it may seem obvious, but what's going to resonate with your audience and with different people. I also think about the slog it took in North Carolina to finally get to Medicaid expansion, and when did the light bulbs go on? And it probably took just a lot of trial and error and continuing to talk about the benefits of having healthy people to get there. So I don't know that I have any great insights. If I really knew what worked, I probably would be writing a book, but hopefully that's helpful.
Yeah, I want to say something on the story, Patty, and I'm seeing a bunch of questions in the Q&A that I'm dropping some links in for folks, but when we say reform medical necessity or the access criteria, we had to talk to a communications firm, and the way we describe it to non-Medicaid people is remove diagnosis as a prerequisite for care. Now, the Medicaid angle of that is reform your definition of medical necessity in your 1115 way, 19 way, I could technocrat you, but the basic premise is remove diagnosis as a prerequisite for care. So I think there's language we have to all align around that makes this stuff more accessible and commonsensical, then the bureaucrats, you know, and the Medicaid geeks like me, like we gotta, I think, find better language to talk about this work because it makes a lot of sense.
Yeah, I think that's so important, how you translate what the really technical, wonky bureaucrat speak is into normal language. And you know, I will say that sometimes when I'm trying to give the basics on early development and why it's important for policy, I'll actually go back to our 0 to 3 parenting materials because it explains early development in ways that the average person can find accessible, and that includes policymakers. So I think that perhaps we should have a bulletin board somewhere where we post, this is the translation into everyday speech that worked for us.
I just want to add on to, in terms of this conversation around language and what language is used, thinking about making sure the messaging is also resonating with people whom are going to be accessing it. Yes, it needs to be simplified and understandable for broad audiences, but making sure that the points that are being uplifted resonate with communities and that the messaging comes from them. If it's a conversation in terms of this is the technical stuff, let's talk this out. What does this look like? How can we message this? Messaging coming from within communities who are ultimately going to be the ones who are ideally benefiting equitably from these policies and programs is ideal. Using language that is reflective of the languages that they would use so that we are socializing the ideas collaboratively and doing it in community to make sure that they are something that the communities want and need and prefer. And then we're not back into this loop of, well, we had the money, we had the things, we had the policies and no one cared, but it's just because it didn't resonate. They didn't understand it. They didn't care. You're not making it impactful for their everyday lives.
Definitely. Thank you all so much. And I know we are getting close to time, closer to the top of the hour, and we've got some great questions from the audience, and I do want to make sure that we have some time for a few of those. But I have one last prep question for our panelists. We know that part of the struggle of doing the work around advancing the social determinants of health is that these factors intersect with such a wide range of issues and policy areas. And it can be challenging, particularly around a shifting political landscape, to identify a short list of policy priorities to rally around. I'm wondering if each of you wanted to speak a little bit about, just to respond to this and to tell us about what you think the policy priorities should be for the next 3 to 5 years. Alicia, did you want to start us off?
We're aligned. I was coming up here already. Yes, I'll do this quickly so we can get to some Q&A. So really sticking firm to what I've shared today, I will say the answer to that question will look different based on who is connected to those policies and what their needs are. So, because even when there are clear overarching priorities of thriving, healthy, healed children and families and communities who live in a just society where race does not dictate your well-being, there's still no one standard way to get there. So over the next 3 to 5 years, policy priorities should focus on shifting power towards those who have historically and are presently marginalized and have the experiences, needs, and norms to be able to shift that power. Those who have the knowledge and expertise, again, experience to craft policy, guide resources, implement programs that would best serve their communities. And this will require trust building and must include compensation as well as genuine shifts in power dynamics as well as decision making. So whatever those priorities are, they should be holistic and account for interconnected needs, as well as existing systems and institutional barriers that prevent those needs from being met. So for example, quick example, when thinking about increasing access to childcare as a policy priority, we must also think about how providers and parents are getting to that care. So there's transportation that we need to think about and look at. When we're thinking about expanding the supply of childcare, since the majority of care does take place in home-based settings, there must also be considerations around housing policy. And finally, those priorities, and this can really be a priority on its own, really must be robustly funded, and that funding has to be sustained. Otherwise, limited and inconsistent investments will honestly further exacerbate inequities and harms too.
Alex, did you want to respond to this next?
I feel like when I talk after Alicia, I just want to say what she said. So mostly what she said. But so to crosswalk that to a few more specifics, in addition to transportation and childcare, like we simply must reimagine the provider class. Because what we're currently doing is pathologizing the experience of low-income community, largely to justify a paycheck for a professional class that does not resemble the beneficiary class. So, and that's a very, very difficult thing to undo. And it's nobody sitting in the back room figuring out how to mess people up. It's how we built the system. So to undo that system, we have to formally create family sustaining employment opportunities for impacted communities. I think that is among the most exciting and interesting kind of opportunities in Medicaid. At this federal level, we got to go after FMAP. So sorry to get all technical for the non-Medicaid people here. Like you can think about something else for a second, but the feds pay a percentage of Medicaid at different levels for different things. Like, remember, Medicaid is a pot of gold in DC. States put up $1 to get $1. That's kind of how it works. But that ratio is different. And I think for little kids, we should increase the ratio that the feds offer. I think it's a pressing policy opportunity. And the reason is another one that Alicia referenced, which is the feds have to quit one-timing us. So those of us who've been running safety net systems, like getting the ambulance there on time, keeping the public hospitals open, we are going from one-time initiative to one-time initiative. Like, and it's not, you can't run a system that way. We need to create sustainable ongoing funding streams tied to individual beneficiaries that systems can learn and grow in. So quit it with the big pronouncements of grant programs and go at the fundamental architectural reimbursement streams like Medicaid, including FMAP.
Thanks, Alex. And Patty, did you want to respond to this next?
Sure. I hope my internet connection will stay stable. So yeah, I think that's really important. The underlying issue of having these really durable, what we call big, bold baby agendas out there is really important. The durable policies, not just little grants that we all spend so much time spinning our wheels and they spend a few dollars and then they go away, but really rethinking some of those things. As I mentioned earlier, I think maternal health is just a crisis we can't ignore. And thinking about Alicia's comments, I think you're so right, shifting power to communities where the people who are experiencing these issues live and have solutions and want to develop them. But I think that is just a problem that has to be tackled. Childcare, of course, and again, I'm like Alex, I'll just ditto Alicia on that, but you can't have a conversation about policies for families without addressing the childcare need. And of course, this companion family policy, paid family and medical leave, which, and I think it's important that people understand how, and in California, I guess the research has really shown that it really promotes equity of people who are able to afford to take leave to time, especially to care for newborns or newly adopted babies or young children, and how that really gives the opportunity that may not have been there. And last, as I mentioned, families' economic security, the fact that there's so many babies in poverty. We're working on the next State of Babies yearbook, putting it together right now. And in analyzing deep poverty, there are Black infants and toddlers and Native American infants and toddlers where 20% live in not just in poverty, but in deep poverty. And that is just truly alarming and disturbing. So taking a number of different efforts to increase income, increase wages, increase the types of employment opportunities, as well as bringing back the expanded and fully refundable child tax credit, I think are policies that are really have to be on the table as we work toward, a future where some of those policies might be possible.
Thank you all. And I'm going to start jumping over to a few questions from our audience. We have one question directed for Alicia first. What recommendations might you make for ensuring state-level initiatives call for more transparent and inclusive data and data processes? As our society becomes highly digital, it seems the tracking and reporting is becoming highly individualized.
Yes. In terms, can you repeat the question one more time? My brain is buzzing with so many conversations that we had today.
Of course. What recommendations might you make for ensuring state-level initiatives call for more transparent and inclusive data? And as our society becomes highly digital, it seems the tracking and reporting is becoming highly individualized.
Yes, thank you. That was helpful. So I think recommendations to ensure that state level data are inclusive are, again, going to come from communities. I know that this is like a broken record that I am saying, but again, even within a state, within a county, within a city, though the way that states may have interactions, outreach, and engagement could look very different from one community to another. So there needs to be variations around what this looks like in the attempts to gather this data, build partnerships with communities, and think about what that looks like from their perspective. So this may look like we have to have meetings that are in the evenings or at night. Maybe we are going to school functions. Maybe there are doctor's offices. Are there other places in community connecting places where parents are, where we can have conversations? Are there tables that already exist in communities? I think there's this idea that we have to go into communities and get the data and do this work. A lot of this work is already happening. A lot of people are already very well informed of what they need and what they want to meet those needs. And so we have to be able to work with communities to get that. I do agree in terms of the data being very individualized and individual level. And I think that is also a way that harm is exacted, because it kind of falls into this trap to look at individual outcomes and how people are doing, as opposed to the resources and supports that they had access to in their communities. And so if we're looking at outcomes without seeing the actual inputs and what's going into these communities, it's really creating a half picture or half truth of what's actually happening. And I think that was, there's lots of other questions. Hopefully that was clear, but please feel free for you to email and reach out to me.
Yeah, thank you. That was very helpful. Let's see. So this question I suppose is directed towards Patty, but all of our panelists feel free to speak on this. Can you speak to what successes, if any, we have seen in reducing Black maternal and infant mortality?
I think so. I think there are approaches that really work. I think that it is really solutions that come from within communities. Alex mentioned reimbursing doulas and through Medicaid. That's one approach. I just think there are a lot of different approaches that need to be it's made available and supported and promoted. But I think that short answer to that question is no, we've not made any progress. Yeah. Black maternal mortality is getting worse and worse and worse, and infant mortality, I think is not really improving. And so that's why I think it is a real crisis. I don't think that it's because they're not solutions that people don't know about it. It's finding the political will to move things like the omnibus to give a variety of different approaches. Even things like paid family medical leave can help with addressing mental health and allowing women to take care of themselves and birthing people to take care of themselves after giving birth. Certainly in Medicaid expansion, where preconception health is so important, extending Medicaid postpartum for 12 months is states have been snapping that up since the option became available and was made permanent. And so there's just a whole variety of different approaches. And then I think those are sort of broad structural. But then I think there are community level approaches of what does this community need to or want to really shape the services that that the people in the community want and need. And I think we have to empower and as Alicia says, shift the locus of who decides what. I think the most disturbing fact that I've been pulling together on this is the CDC's assessment that 80% of deaths are preventable. And that is just heartbreaking that we're not taking those steps. So I don't think that there's a one broad thing that can be done. I think there are a lot of things that are being tried, and it's a matter of giving communities the wherewithal to make them happen, as well as enacting and promoting these broad policies that can lay the foundation for the more tailored efforts.
I'd love to highlight the Abundant Birth Project, Dr. Zaya Malawa, guaranteed minimum income tied to Black women parenting. Dr. Malawa is an amazing African-American pediatrician in San Francisco who has pioneered this work. Google Abundant Birth Project, Zaya Malawa, and they are showing extraordinary outcomes with relatively modest investment.
Thank you both. Let's see. So this is for the full panel. Alex, you've touched a bit on this in the chat, but if anyone else wants to chime in as well. Are there any other specific programs, practices, or models to promote health equity in early care and education settings not mentioned yet that you'd want to highlight? Any, however you want to take that question, but state or local, yeah.
I just want to highlight this one because Georgia just did it, and I think it's really important to know about. A lot of states have merged their S-CHIP and Medicaid programs. Medicaid is 0 to 138% of federal poverty. S-CHIP is 138 to 250 in many states, right? They become one program, but S-CHIP still has this thing called a health service initiative. So this is not for the uninitiated, everybody. This is a little wonky. S-CHIP HSI. And what that is, it allows you to spend 10% of your S-CHIP allocation on anything you want that has related to kids. And states use it to fund teach, read, write, and sing, home visiting expansion. But Georgia just did it for early childhood mental health consultation. And that's embedded therapists in early childhood settings who are not doing individualized treatment or diagnosing. It's about brokerage. It's a super cool model, early childhood mental health consultation. 0 to 3 is a champion of it. Super dope, culturally concordant. It's great. But it's very difficult to fund in traditional Medicaid spaces because, who's the identified patient with diagnosis? It's difficult. So I would just say to many folk listening, if you want a specific target with flexible dollars to do cool stuff, look at the S-CHIP HSI for early childhood mental health consultation.
Thank you so much, Alex. We are getting very close to the end of our hour. So I know Haley has a few just closing statements. So I'm going to pass it over to her to do that. But thank you so much again to all of our panelists. This was a really great discussion, and we just really appreciate you taking the time out of your schedules to be here today.
Seconding all of that, we still have a lot of discussion left to go on this topic. It is such a huge topic with so much work left to do. So hope to continue this conversation. A huge thank you to our panelists for lending their time and expertise to our chat, and to our audience for joining us today. Please stay tuned for a copy of the recording, which will be available at americanprogress.org/events. You can also watch recordings of other previous events and register for more upcoming. There's always stuff coming out. We will also share some resources with our great audience, including our report series just published from our early childhood team, and some feature work from our incredible panelists, some of which they mentioned today. So for folks who are asking about that, we will make sure that you get those resources. Thank you all again, and we hope you have a wonderful rest of your day.